All right, good afternoon, everybody. Welcome back for the first session in 2020. I hope you all had a good holidays. Go ahead and get your food, but we're going to go and get started because we have a fair amount to cover. So today we're going to talk about the role of stress echo. By now, we've had sessions on left ventricular function, global, regional. So this is basically applying these concepts, but using a stress modality to look for changes of heart function with stress, most commonly caused by ischemia. So what we plan to do today is going to do a little bit review of how we assess wall motion, and then apply that to stress echo to look for ischemia, do a little bit of how to, and talk a little bit about whether strain has any value in this. And then we'll finish with some of the other non-ischemic uses of stress echo. So when we look at regional function, it's part of our assessment of global function. So we are looking for different segments to see how well they thicken and how well they move towards an imaginary center in the cavity. No matter which view we're looking at, we create a center point, and we're looking how well this is moving towards a center point in terms of endocardial movement as well as thickening. And this is, of course, a pretty normal example. We classify then the segments as to normal, hypokinetic, akinetic, dyskinetic, or frankly aneurysmal. One thing about aneurysmal is that to call a segment aneurysmal, one should see a deformity of geometry at end diastole. So if it's only dyskinetic in systole, but in diastole you don't see that aneurysmal deformity, then it's dyskinesia. It should not be called aneurysmal. So here we have an example that does have some wall motion abnormalities. In our lab, we're one of the few that we make a little distinction between mild hypokinesis and hypokinesis. If you look at the ASE guideline statements, they just talk about hypokinesis. So that's just a subtle change that we do in our lab. And this is a patient that has some abnormalities. I think hopefully many of you already are picking it up, that these segments are not thickening properly compared to the septum. In the fourth chamber, everything appears to be okay. But in the short axis, likewise, we see this area here that is not thickening properly, and likewise here. So we make it easier now with the arrows, but hopefully many of you who have rotated to the lab would have seen that. Very importantly, when we do wall motion assessment, either at rest or with stress, is to apply the segmental scoring. An important point that is worth making, notice that this patient right here has some dyskinesia actually, right in that area here. However, just wall motion alone, even akinesia, even dyskinesia, does not imply absence of viability. So segments can be very dysfunctional and still have viability in it. We've known that now with MRI, we think we have learned that lesson very well. But even before MRI, we could see sometimes that these segments would respond to a contractile stimulation with dobutamine. Now, if you have a very thin wall, bright area that is dyskinetic, then your chances for viability are much, much lower because you have thinning and you have some brightness of the wall and the dyskinesia. But overall, as a general concept, hypokinesis, akinesis, or dyskinesia does not necessarily imply lack of viability. So this is the diagram that has been shown in multiple times. By now, everybody here is an expert on that in terms of what territories we assign to a given coronary artery. So we know that if we look at it from this point of view, the anterior septum, anterior wall, it's LAD. Here you start getting into diagonal and OM. Here you start getting into the posterior circulation of the circ or the right, depending on dominance between right and circ. Most of the time, this is right because it's now inferior septum and inferior wall, and so on. So this is very well established. So if you apply this scoring technique to that, today we have 17 segments. For many years, we only had 16 because the little tip of the apex was included in these two segments. But subsequently, it was agreed that for every imaging modality, angiography, CMR, CT, nuclear, and echo, everybody agreed to keep the tip of the apex as an isolated segment, and that created the 17-segment model. So if 1 is normal and 5 is aneurysmal, and if you basically apply one of these numbers to your wall motion assessment, the sum of all segments divided by 17 would give you the score index, and 1 would be normal because all of this would be 1, so it would be 17 divided by 17. So if we go back to our example here, we have some 2s here from the hypokinesia. We have 1s all over, and we have 2s and 3s in here, okay? And maybe even some 4, but I mean, at least 3s. So all of these would give us a 24/17 or a score index of 1.4. And there's a lot of literature showing both at rest as well as with stress that the higher the wall motion score index, the more likely for cardiovascular events when you follow patients. So ejection fraction and wall motion score index are two parameters that have power for predicting events, and that's one reason why we encourage that we do this always systematically, as we do in our day-to-day routine in the lab. So with that review, let's get right on into stress echo. So you all learned this when you were in medical school. This is the ischemic cascade. And for ischemia to occur, first thing that has to happen is a flow heterogeneity. Some areas of the heart are not going to get as good flow as others. So the coronary reserve in those areas is going to be impaired. Today we can measure that in the cath lab with a wire. We can measure that today with PET. We can measure that today, even now, with offline assessment of CT. So that's flow heterogeneity. So modalities that look at flow, such as nuclear SPECT, PET, CMR perfusion, they are going to be assessing that. Importantly, you may have flow heterogeneity without ischemia. They're not equal. So you may have some degree of impairment of coronary reserve, but the cells themselves may not be ischemic. Now, when ischemia occurs, then there's going to be dysfunction of the myocardium. And that dysfunction is what we can pick up with echo, or we can also pick up with CMR if we're doing a dobutamine stress. So that dysfunction can be diastolic or systolic. Unfortunately, we don't have that good diastolic methods to pick it up. So we rely primarily on seeing contractile dysfunction in different segments. So that is the reason why the stress echo comes in as a useful test for detecting ischemia. In theory, not always the case, all of these changes precede the ST changes in DKG, and they all are supposed to precede angina. However, that's not always the case. We see patients that have sometimes severe ST changes, and we lack any findings in the echo, and they get cath and they have disease. So this is sort of the general principle, but not every patient read the book and follow the rules. So this would be a normal stress echo, very nice hyperdynamic function at rest and exercise. And this is an interesting case because this shows you sometimes what we don't see when we do a resting study. So if this is somebody that came into the hospital with chest pain, and we do a resting echo, and we see this, what would we say? Well, we say that the EF looks kind of in a borderline low, maybe low 50s, right around 50%. Segments are contracting, but they certainly are not hyperdynamic or anything. We might even wonder about the apex right here not being that well. So this would be read like, low normal EF, around 50%, wall motion, the low normal range, concern with maybe the apex. I mean, you would have one of those readings. And what is this? Could this patient have been in unstable angina and ischemic at the time the resting echo was done? Maybe, right? But in reality, this is not a resting study. In reality, what this is the stress component of a stress echo. So now we see the same patient at rest, and you can see beautiful contraction of the septum, inferolateral wall, short axis, 4-chamber, 2-chamber, perfectly normal at rest. And this is what happened when this patient stepped down from the treadmill and had immediate imaging. So now, when we look at this, the changes are quite dramatic. And of course, this is a very dramatic change, which would make you concerned with a left main, multivessel disease, and so on. Now, if I ask any one of you, why is this dramatic? What is it that your eye is seeing that is saying, whoa, that's not good? So let's stop for a second and let's kind of think through why is it that we so rapidly appreciate that. And remember, as we talked a little bit about this when we were doing resting function, our eyes are great at relative changes. We don't do well with absolute changes, but relative, we do very well. And basically what we're seeing is that you're seeing the shortening of this cavity from diastole to systole that suddenly is much less here. The other thing that is very helpful is to look at the end-systolic size of the cavity, not only global, but regional in terms of diameters. And you can see here, okay. You can see here, if I can stop it on the right time, that now these diameters here overall are larger than what we were seeing here at end systole. So cavity dilation at end systole, whether regional or global. In fact, most of the time it's not global, it's regional. If it's global, then you have a really multi-vessel type of involvement. But look for regional end systolic cavity enlargement. And the eye picks that up very nicely. And when I'm looking at stress echo, I look for these findings even before I start looking at the actual movement of the walls, because these findings they jump at you very easily. Okay? So, remember that ischemia is transient. However, it's transient, but it's not fleeting. It does last a little bit. We learned that many, many, many years ago in the dog lab. If you basically quickly occluded the LAD and you did it for 1 minute, when you released it, you could see ischemia for 10, 15, 20, 30 minutes. And that's the stoning effect. So there is some degree of myocardial stoning that is our friend when we are doing stress echo with a treadmill. So the dysfunction may last minutes or hours depending on the magnitude of the stoning, or be chronic, as in the case of hibernation. Like you may be imaging somebody in the verge of having unstable angina, and you may be seeing a lot of wall motion abnormalities. So stress echo, exercise, exercise, exercise. That's the most preferred way. Pharmacologic, dobutamine has pretty much become the standard. Vasodilators, I think, have gone by the website. However, there are some adjuncts. So when you're doing dobutamine, you can use atropine to help you get that heart rate up to 85%. And some labs also apply a little bit of hand grip, because now with the hand grip, you put a little bit of additional afterload and a faster heart rate with a little more afterload, you can sometimes induce the ischemia. And the reason for the adjuncts is that in general, another general rule, pharmacologic stress echo is less sensitive than exercise. And that's why the adjuncts came up, because we're trying to do everything we can to increase the sensitivity to be a little bit closer to what exercise can give you. So we start with the treadmill. That's the one that is done very easily in the outpatient area. We use a standardized protocol for exercise, usually the Bruce protocol. Most people have a treadmill in their office and an echo machine, so it's widely available and easy to do, but it's actually the most difficult. So from the point of view of the technical components of a stress echo, the stress on the sonographer is the greatest with the treadmill, because you're trying to really, number one, image very quickly after the patient comes out of the treadmill, and second, you're trying to reproduce same tomographic planes that you did get at rest. And those resting images are in your memory. You're not seeing them anywhere. So now you're going right after exercise, and you're trying to get in there and get that 4-chamber, that 2-chamber, those parasternal views, and try to make them as close as possible to what we had at rest. And it's not always the case, which is one of the issues we have to deal with when evaluating these cases. Second thing is that although there is some stoning, if the ischemia didn't last too long, he might recover very fast. And that's why the dogma is that you want to obtain all your imaging within 90 seconds. So if it took you 2 or 3 minutes to get those last couple of pictures, those last couple of pictures may already be fully recovered. Now, if the ischemia did last for a while, then you may have a little bit more luxury. But since you don't know that information, that is so crucial that you get everything done within 90 seconds, because that appears to be, and of course, if you get it within 60, that's even better. And that's why, truly, in an echo lab, treadmill stress echo should be done by the most experienced sonographers. You do not put a new rookie to do stress echoes on a treadmill. You start them with Dobutamine, which is very easy, more relaxing, and then as you learn your way, you get into doing it with the treadmill. Best accuracy when patients reaches 85% of maximal predicted heart rate. Maximal predicted heart rate is what? 220 minus H. Although some people have more recently challenged that equation. So if my maximal predicted heart rate is 150, you want to get me to 85% of 150 to have an adequate test. Now, very importantly, I get off the treadmill, I get on the stretcher, you guys start imaging, my heart rate now is 100. Does that make the stress echo bad? No, because what's important is what I reached during the treadmill. There's some people that recover very nicely, and within 60 seconds, they're down to 100. Don't worry about it. I see sometimes people saying the patient did not have adequate heart rate because at the time of imaging, it was 100. No, it's what they reached. So if they reach 85%, and if we successfully got all the images in 90 seconds, you have an adequate test. Very important, because I see sometimes people making that mistake. It's the heart rate at the time of image acquisition is not important. It's the heart rate the patient reached, okay? Now, this is historical data way back from, my God, when was this? 1992. Some of you might not have been around at that time. And this was a classic study because it was the first time that the same patient at the same time simultaneously had both nuclear and echo. And we basically showed pretty good agreement between the two. And it's interesting that the disagreements were about equally shared between an echo that was inaccurate, but the nuclear was accurate, or a nuclear that was inaccurate, but the echo was accurate. There was no predilection of one for the other. Subsequently, after that, other studies came up, and this was one that is quoted a lot because it was a meta-analysis, again showing that very comparable sensitivities and specificities for the nuclear and the echo, although it was claimed that echo may be a little bit more specific. My own bias is that on the street, as we call it, both have problems. I think specificity of stress echo and stress nuclear done outside in average labs, I would say 60% would be a decent number to quote for both. I think we all see patients that come back to our office with positive nuclears. As you know, nuclear is often not quantitated in the street, and we do further studies, and they were false positive, and the same thing happens with stress echo. So I think that those are limitations that we should be aware of. All right, so again, reviewing some of these practical tips, okay? What do you think of this exercise echo? This is resting, and this is post, okay? Is this a normal or abnormal? Anybody? Carlos? Abnormal, okay, all right. Hopefully, now, again, evaluate end-systolic cavity side, both global and regional, and then you may see some distortion of geometry, okay? So here, let me see if I can stop in time there. Not so easy. Maybe here. Here we go. So this cavity is bigger than here, and also there's a little bit of geometric distortion, so yes, with a little bit more dilation towards the apex than at the base, where in fact it should be the opposite, right? The cavity should be smaller towards the apex than to the base. Of course, we see this better in real time. So you can see very nicely smaller cavity at the apex compared to base, and here is the opposite. It's a bigger cavity at the apex compared to the base. And short axis is very helpful. Short axes give you all the territories very nicely. And again, this is a global response. I mean, there's a lot of dysfunction in this particular example. So detections are roughly in that 85% range for both nuclear and echo. Prognosis, very similar. These were the same group of patients. We lost a few, so we ended up with 250, followed for 5 years, and again, the curves very similar for normal versus positive. The advantage of this treadmill stress echo is that in addition to your imaging, you have the treadmill. And there's a lot of literature on the treadmill that we have used. And in this particular study, done again in 2003, we developed a risk index, which you don't have to mathematically do in every patient, but it's the concept that if you combine the wall motion changes, so the wall motion score, and the ST changes, you get even a more strong prediction of cardiovascular events than either one of the two alone. So that's one of the advantages of doing a treadmill, because the Bruce protocol has been done for 40 years, 50 years, very well established, a lot of literature written on it in terms of duration of exercise, pain or absence of pain or no pain, or absence or presence of pain, ST changes, and so on. So you throw that into the imaging component, you have a strong predictor for events. Now, bicycle has its own advantages too. First, patients often like it. If you have a patient that is scared of the treadmill, don't go straight to Dobutamine. Think of a bike, because it's comfortable, patients are secure, they have no fear of falling, and you have multiple stages. So now you can see improvement in function during exercise and worsening if at peak exercise there is ischemia. So now you have progressive changes you can follow, number one. You have a standard protocol. Number two, if for any reason your peak images are not that good, no problem. When the patient stops the bike, now you have a post-exercise that you can do within 10 seconds, not 90. Patient doesn't have to get out from anywhere. They don't have to come out of a treadmill. They don't have to lay down on a stretcher. They're right there. So if you struggle at peak, no problem. Patient reach their peak, you let them do their peak, you get your EKG, stop. And immediately start imaging. So it's post, but it's so close to peak that now you're going to get your images within 20, 30 seconds, and you should be able to capture ischemia if it was there. So that's another big advantage of the bike. And it's a good place to initiate your rookies. So you start your rookies with Dobutamine, you move them to bike, and treadmill should be the last part. By then, they should have learned enough that they can now start managing the challenges of a treadmill. So let's look at this case. What do you think? Who wants to take a peek at this one? You have a resting, beautiful 4-chamber, 25 watts, 50 watts, and the peak. So, and here are your tips. Just again, going through them, right? So using these concepts, who wants to take a quick track at it? Nobody? Everybody's like stoned? Okay. So you may be right. Let me see if I can stop. There we go. All right. Now, the cavity is still relatively small here, and everything moved in here. Look at that end systole. Unfortunately, I cannot show them together because obviously the interval have changed. So that's your end systole at rest, and that's your end systole with exercise. So you are right. There may be a little bit of dilation here, but where is the most dramatic dilation? Yeah, at the base. So now, fine, great. We saw that. Now the question is, who's guilty? This guy or this guy? All right, let's go back. The arrow helped. All right. But watch it. Now that we have said, okay, there's something wrong here. This ain't normal, okay? And there's regional dilation at end systole. Now we focus more into your segments, okay? So now we have how much thickening we see here versus how much thickening we see here. And I agree, there's less thickening here. Now, which vessel gives you the basal inferior septum? Anybody in the cath lab? Anyone? Huh? RCA, of course. So inferior septum is RCA territory. Yeah. Towards the apex, if we get here, this is not bad. This is coming in pretty nicely. This is coming in a little sluggish, but this is the worst. Okay? So we have now basically either a very prominent circ, right, or a prominent right. That becomes more difficult. But is there any doubt in any one of you that this is an abnormal stress echo? There should not be, right? There's good imaging, good quality, and clearly it flunked several of our tips. There was regional dilation, maybe even global. I would say probably even global, because I think if we were to trace, the end systolic volume would be bigger here than here. So I think it was even global. Okay. Right? And this guy did have a dominant circ. So with bike, the other very important thing that we need to remember, heart rate is meaningless with a bike. Don't worry about the patient only got to 65 or 70% of their predicted max. Never write that as a limitation, because rarely do we get people to 85% heart rate. So what we learned very early when this study was done, which was done with patients that everybody had the treadmill and the bike. So you had to do 2 stresses in everybody and then a cath. Everyone got cath. In the days that we could do this, now it's more difficult to do it. And what we found that basically they were very similar in accuracy. The accuracies were very similar between the two. But what we learned that the equivalence of an 85% heart rate threshold for treadmill is a 2200 double product threshold. So because blood pressure gets so much higher in the supine bike, what became very important is that your patient hits a $2,200 dollar product. If they do, you got a successful bike from the point of view of reaching the criteria to be able to see ischemia, okay? Now, the bike has other advantages. As I said earlier, it's easier on the sonographer, and then you have room for other things. You can do a little more diastolic function, PA pressure, valve assessment if you're dealing with mitral stenosis, and so on. So the bike obviously gives you comfort for a lot of other things. The worst of all is dobutamine. You know that I'm not a fan of dobutamine. Patients don't like it. They get a lot of palpitation. You get a 1% risk of AFib. Every series have shown 1% AFib. You can get a lot of PVCs. You can get some non-sustained VTAC. And occasionally you can get a little bit of more trouble. But that's very rare. Overall, the safety is not a problem. The problem is the cavities get very small, very small. Now, there are two kinds of protocols that labs do. This is one very commonly used. For the quad screen, they put a resting, a 10 mic, a peak dose, and a post. Very commonly done by people. We tend to do resting 5, 10, and peak. Reason being that since we do a lot of viability, this protocol is a little nicer to look for subtle changes and improvement in contractile reserve. So we do not put a post. We do look at post later, but the post is not placed in your traditional quad. But there's nothing wrong with this approach also. This is done in many labs. They do a low dose, a high dose, and a post. Now, the tips are the same, okay? The same tips. And this is a very positive test. I'm not going to ask you on this one because if nobody sees that, then you really should be going into EP. So we see nicely here, end-systolic cavity, very nicely. See how much improvement. In fact, this is picking up even a little bit more than resting. And then bingo, all this area here becomes abnormal. But again, how come we see it so quickly? For the same reason that we just said, okay? We can see that this cavity is nice and small at end systole, and it's much bigger at end systole here. So there's this regional dilation. And then, of course, once we have detected that, then we spend time going through every segment, and we can see that there's no thickening happening anywhere here, all the way up to here. Maybe there's a little bit of thickening beginning to happen right here. So this is a very prominent LAD abnormality, and amen. So this was a nice dobutamine. Problem is that they're not always like that. And sometimes the cavities get so small that it's harder to. So let's look at this one. What do you think of this one? Small cavities to start with, okay? So resting, 5, 10, and peak. So both for bicycle and for dobutamine, we do not compare peak to rest. We do peak to whatever highest augmentation we saw. In fact, we did a study, some years back, showing very nicely that if you only put the peak with the rest, you lose a lot of ischemia. But if you then look at everything, what you see is that there's augmentation with the low levels of stress and then worsening with the peak. Particularly when patients have resting abnormalities, this becomes very important that we look at peak versus the best low stress, either for a bike or for a dobutamine. So if we do that, we will compare not this with this, but this with this, right? That with this. And what do you all think? Is this a normal stress echo? Peter? No. Yeah. Yeah. And we can nicely see, I'll eventually get it. There we go. End systolic cavity here. versus here. So there is an overall global dilation in the short axis view at end systole compared to the best dobutamine, even this one here, and likewise here. If you look at diameters across, they're all bigger at end systole than what we had here or we had here. So we have a response. We don't see much destruction of geometry, so it's not normal, but it's kind of global. And this is interesting. Anytime we see a global abnormality with a stress echo, whether it is a treadmill, whether it is a bike, or whether it is a dobutamine, it could be multivessel ischemia, left main, multivessel, yes. But it could also be a functional abnormality because of either a ventricle that has some cardiomyopathy or excessive loading. So anytime that you see global dysfunction, look at the overall picture. Heart rate, blood pressure. This could be a dobutamine that hit at 250 or 230 or 240 systolic blood pressure. So the problem with global dysfunction is that it could be the worst of the worst, multivessel disease or left main, or it could be a dysfunction happening because of changes in loading conditions and so on. So it takes usually a little bit more assessment of other findings to put the whole thing together. And sometimes in the report, we have to be a little hedging and say, the response is very abnormal and consistent with multivessel disease, but, could also be due to blah, 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 okay? However, this is my patient, he's getting cath. All right, so dobutamine has the advantage that you can do, likewise, multiple imaging stages, just like a bike, easy on a sonographer, okay? And it's also very good for low EF. In fact, dobutamine is the preferred test for a low EF. So if you have a patient with low EF, now you're looking at viability issues. And you want to go gentle with dobutamine because you want to see that segments improve and worsen. And dobutamine gives you a more gentle way of doing that than a bike, and forget about a treadmill. Treadmills are basically worthless if you have a patient with a bad EF. Because you're going to have bad at rest, bad after exercise, what was it? You don't know. So do not bother with a treadmill if you're looking for bad EF viability issues. We're going to have a whole session on viability, so I'm going to let Dr. Sogby spend more time with that. But with the viability, the important thing is that you want to see how well those segments improve with low dose and whether they worsen with a high dose. So dobutamine is the preferred test whenever you have a bad EF patient. Limitation is that it is less sensitive than exercise, particularly if you don't reach that magic 85%. That's why atropine is often used if you can. Also, if you have hypertension, concentric LVH, small cavities, the test becomes extremely tough to read. And we have had some serious misses of bad disease over the last 4 decades in people like that. So I would never order myself a dobutamine stress echo in a patient that I'm expected them to have concentric LVH. You'll never be sure what the hell you got. We have so many other good options today, all the way to CT, that, why waste money and possible risk to a patient and at the end not know what you have. So this is a real limitation, concentric LVH. Of course, we have arrhythmias. You get no data in terms of capacity of the patient, and the EKG is worthless in most cases. So bottom line, if you're a clinician ordering, exercise, exercise, exercise. If the patient is a little bit scared of a treadmill, do a bike. Many patients that cannot do well on a treadmill, they'll do on a bike. Even people with a little bit of knee discomfort, you put them on a bike and they manage it. In fact, bicycle exercise is recommended by orthopedic surgeons for people who have bad knees. So the vitamins differ for people who cannot exercise, of course. Post-MI, just because there's more data in the literature with that. Preoperative risk assessment, also because there's more literature on that. I have not ordered this in years. If I'm going to be concerned about somebody for pre-op, I'll do a nuclear. If they cannot exercise. If they can exercise, I'll do a stress echo. And of course, low EF. So they're valid tests. They all have very similar appropriateness as a nuclear. If you put this and nuclear together, they're exactly the same in terms of what are the recommendations for appropriateness used in the clinical setting. Limitation is a subjective, as we have said. So as a reader, you have to have a lot of skills in the subjective assessment of wall motion. Sonographers have to be skilled. And of course, you have this problem of the accuracy varying between experienced and non-experienced centers. And we see this, to be honest, with nuclear too. All right. You see, this is just to bring up the fact that contrast is very helpful. Without contrast, we could maybe be a little worried here, but I mean, to be honest, this would have been a worthless test without contrast. And this is the same one you saw earlier where we had a very prominent abnormality at the apex. So contrast is like turning the lights on. However, in this very nice study done with 108 patients, it was also shown that if you have good imaging at rest, contrast doesn't necessarily help you. In fact, it can be a problem. And when more than 2 segments could not be seen at rest, that's when we get your biggest bang for your bucks in terms of the benefit of contrast. If 1 or 2 segments are not seen, you don't get much benefit. And if you get a great study, the contrast doesn't give you anything. And sometimes it could be a distraction because of the effect of attenuation. So the money is when at rest, you have trouble seeing 2 or more segments. All right, so this patient had a stress echo for pre-op. It is normal or abnormal? Look at the end-systolic cavity here. Now, and here. Now. What do you think? Where do you see an abnormality? Here? Right here? Is that what you're concerned? Okay. Now, interestingly, look at the 2-chamber. Do you see anything here? Looks great, right? Okay. So now, this is a very nice example because actually this was the person who was reading this read it as positive. But look at it. And I don't know that I can do it. It's going to be hard to do. If I grab in here? Oh, you guys are so smart. Okay. Oh, great. Okay, this is end-systole. That doesn't look too bad. Now, this is early diastole. See it? Right here. So what we have here is now. That's in early diastole. So actually what this is in coordinate relaxation. This segment is relaxing a little sooner than the other ones. So you have this in very early diastole, this wave, where this, like that, okay? So this is the importance of, in the lab, we have the advantage of slowing down the image, going frame by frame, and I didn't know we could do that. That's great. So I just hold it. Oh, nice. See there? You see it now, right there in diastole. This is diastole now. We have passed systole. This wasn't systole. And at end systole, actually, there was no problem. So one thing you can do in the lab is you can bring your bar, your time bar, to the peak of the T wave and only see systole and have no diastole. So those are little tricks that in the digital environment that we can do. So this is an example of somebody with inferior wall abnormality. This patient did have an RCA abnormality. And this is the Achilles tendon of stress echo. The base of the inferior wall is a troublemaker. And it's a troublemaker even for people like myself and Dr. Sogby at times. We scratch our heads a lot more in this area than in any other area. So I have shown you LADs, I've shown you some circs. This is the RCA. If the whole inferior wall goes down, it's easy. But when it's only this area here, it's tough because there is normal heterogeneity. The inferior base to start with is never as contractile as everything else, even at rest. And it's a matter of, did it get worse? So what we see here now, if you can follow it with me, There's no thickening in systole. And I'm going to try to follow the same trick again. I'm not getting it. This is an old clip. Maybe this doesn't have it. But I don't know if you can see it, that you start seeing thickening in diastole. Watch when the mitral valve starts to open. Now. So you actually see that segment thicken very early in diastole, but it didn't thicken in systole. And what is that phenomenon called? Anyone? Post-systolic thickening, right. And it is pathognomonic of ischemia. That's exactly what you see in the doc lab when you clip a vessel. Very first thing you see is ekinesis, no thickening in systole, early diastole, boom, it thickens. Eventually, it may not thicken at all. But in early ischemia, you see this diastole. Why? Because the left ventricular pressure is dropping, and the afterload is dropping. And one of the things that happens with ischemia is that the contraction, the tension building in the myocardium is slowed down. So what happens is when the LV pressure is dropping, suddenly the afterload is dropping like crazy. And now the wall goes, oh, thank you, boom, and it thickens for a little bit. So you get this post-systolic thickening. So that's one thing we try to catch, if we can, with the eye, or going frame by frame. And this patient did have, now, what about this one? Is this the same thing or not? Kind of look like the same. But I'm showing you these cases because this is where we all scratch our heads. And by the way, if you're a reader, don't be embarrassed. Don't feel humiliated. Pick up the phone and call any one of us. Hey, let's put another pair of eyes. What do you guys think? There's nothing wrong with that. Dr. Sabia and I do it all the time. There are times when we scratch our head. And this is one of those segments. The inferior base, I think, is the most problematic for all of them. All right. This is another circ. I want to go a little faster, but again, you can see very nicely how this is lagging behind. Again, note the end systolic diameter here, and watch it here. It's a little more enlarged right now. And maybe this one I can do the trick that you guys were telling me. Yeah, here we go. Yeah. So look at that end systolic here versus the resting. So this is an OM. This is very typical of an OM. Everything contracts nicely here, nicely there, but this area right here is lagging behind. Circs, if you look at overall sensitivity, specificity, LAD is number 1, RCA number 2, circ number 3, in terms of being able to pick up with stress echo. And this is another dobutamine with a small cavity. I'm going to bypass this one so that we move. So strain, in theory, should be great, right? We should be able to do a lot of great things with strain. This is inferior wall abnormality at rest, and the strain shows it very nicely. And this patient has global dysfunction and ekinesis in this area. And we can see global abnormalities of strain, but then much worse in all this territory here. And then here, this one looks like maybe this is not coming so well in the inferior base. And likewise, we see abnormalities there. And this is one where actually was interesting because the apex didn't look so bad, but the strain picked up a really bad area of the apex. So the sonographer actually picked this up and repositioned the transducer, and now it got a beautiful abnormality without the strain. So strain certainly can be very helpful. So you go, my goodness, if it's that good, we should be able to go from normal at rest to a stress and say, oh, wow, there's an LAD or there's an RCA or there's a circ. So initial studies suggested that, yeah, there was good response, good accuracy. So that was encouraging. And then this study came up, which is one of the most recent ones, where they compare the eye with stress, and they look at experts and trainees. And the bottom line, this is, of course, your best case, right? You can see very nicely how the strain is picking up the abnormalities. But the reality was that when they actually look at the accuracy, with angiography as the standard, the strain didn't help that much. and there were a lot of problems. So perhaps because of the technical problems of acquiring imaging when you have fast heart rates, the fact that you cannot use contrast because contrast, unfortunately, strain does not pick up with contrast. The fact is that we don't have today a consistent role for its use in stress echo. Even though papers have been published, it's a problem. And as you know, we're not doing it routinely. So let's finish up with a little bit of the non-ischemic uses. And this is, I hope you have some sonographers still here, because I think this is very important. So when a normal person exercises, this is what you get. You get increasing blood pressure, shortening of end-systolic volumes, and therefore an increase in stroke volume, and the feeling part remains about the same. With diastolic heart failure, patients have what is called systolic, lack of systolic elasticity, and therefore they hit a wall. And systolic volume does not get smaller, blood pressure does go up, and the response is one of a high afterload with the loop going up like this, feeling pressures going up. So this is a normal, and this is a patient with HFpEF, and this is the typical response. So in theory, we should be able to pick this up with stress, with exercise. And in fact, we can. And the typical findings, which you have seen about it before, is that with exercise, the E velocity will go up, but the E over E prime will also go up because the E prime itself doesn't change much. So normally, the E prime goes up, the E goes up, but the ratio stays the same. With HFpEF, the E prime stays the same, the E velocity goes up, the ratio goes up, and of course, TR velocity goes up because they get pulmonary hypertension. So it's this combination of findings that allows you to say that that patient has high feeling pressure with exercise. And there have been some studies where they have been simultaneously done, showing nicely that the E over E prime with exercise can detect those patients very nicely. Here we have another study. And this one that I'm showing you next was a very important study showing with cath and echo that PA pressures with stress were quite accurately picked up. So this gives you an ability to look at what's happening with the physiology of feeling in those patients. And I think we should all make this a routine of all of our stress echoes. There's no reason why not any patient that gets a stress echo with exercise, not dobutamine, should not have, after finishing your imaging, an assessment of TR, transmittal velocity, and lateral septal E primes. It's there. It takes literally 2 minutes to get, and we can then assess, because very nicely has been shown that the stoning phenomenon applies to diastole as well as systole. In fact, there is some experimental data suggesting that the stoning of diastole may last longer than systole. So if it took you, 90 seconds to get your imaging, you still may be stoning, have enough stoning that you can pick up that elevation of feeling pressures and PA pressures. So I would like to suggest that we make it sort of a routine that our sonographers, both at Fondren and in our clinic, routinely incorporate this because it's free there. It's free data. And if the patient's symptom is primary dyspnea, this should be really mandatory. So I wanted to finish with that because I feel very, very strongly about this. I mean, it's data that is available. It takes very little extra time. And we don't do it, we miss in the opportunity of knowing even more about the potential impact of the ischemia on the physiology of the patient, which has also value in making decisions for treatment and also in predicting events in the future. And for people who might have HFpEF that you are not so sure when you see them in the clinic, adding that component to the stress echo really can be very helpful. And of course, I'm not going to talk about it, but you all know, and previous talks we have done, that we can use exercise stress to assess pulmonary pressures in patients with mitral valve disease, people who have mild to moderate pulmonary hypertension, and of course, we use dobutamine in aortic stenosis. So I'll stop at this point, and we have hopefully maybe 1 or 2 minutes for questions. Thank you very much for your attention. And any questions? Clear, easy, ready to roll? All right, very good, thank you guys.